Welcome to my YouTube channel, TutorMed, where everything medicine is simplified. This will be our 5th video in obstetrics and gynecology, and in this video, we want to explain some basic obstetric concepts. What you need to establish initially when taking a history from a pregnant woman. I want to thank all TutorMed subscribers for the support so far, and if you are yet to hit the subscribe and notification button, kindly support us by doing that now, and like and share this video if you find it very helpful. Alright guys, grab your notepads and let's get started. Well folks, for an obstetric or pregnant woman, after you've asked about her demography, which is her name, her age, etc., the initial basic information you need to establish include 1. Her obstetric score, otherwise known as the GPA system. The GPA stands for Gravidity, Parity, Abortion, Notation. The second thing you need to establish is her last menstrual period, abbreviated as her LMP. We will discuss this in detail soon. The third thing is her expected date of delivery, which crudely speaking is when the woman is predicted to deliver her baby. Then the gestational age, which is the duration of pregnancy at any given time, to simply put. So we need to understand these 4 obstetric concepts because an accurate obstetric history taking depends on understanding these concepts. And so let's begin with the obstetric score, or the GPA notation. The G stands for gravidity. What is gravidity? Gravidity is the total number of confirmed pregnancies that a woman has had in the past, irrespective of their outcome, and also her current pregnancy, that is if she is pregnant. Now let's take some time to understand this. We said total number of confirmed, emphasis on confirmed pregnancies because there is a condition known as pseudocyesis, a psychological condition in which the woman thinks she is pregnant but is not. So she may tell you that it was pregnancy, but you need to verify if that was a confirmed pregnancy by asking whether a beta HCG test was done and whether the pregnancy was confirmed by scan. Now, irrespective of the outcomes of the pregnancy, such as the pregnancy may have ended up as an ectopic pregnancy or a miscarriage, stroke an abortion, or it may have ended up in a stillbirth or even the live birth you are expecting. The point is that the woman had a confirmed pregnancy. And if she is currently confirmed pregnant, it should also be added to her gravidity. So take this woman who has had 4 confirmed pregnancies in the past and is currently pregnant. She will tell you, I have been pregnant for 5 times, or I've been pregnant 5 times. So irrespective of the outcome, because she had 5 confirmed pregnancies, or she has 4 confirmed pregnancies plus his or her current pregnancy, she is described as Gravida 5, which is simply abbreviated as G5. Very good. And so on this slide, let's briefly explain some terms associated with gravidity. The first term is nulli gravida. Now, null is an English word meaning empty or zero. So a nulli gravida is a woman who has not had a confirmed pregnancy before. It means she has 0 pregnancy. Then we have primigravida. Primi in Latin means first. And so for a primigravida, she has had 1 pregnancy experience before, or she is currently pregnant, and that is her first. So primigravida has been pregnant once before. So quickly, let's go through these short exercises. A woman with 4 pregnancies will be described as, yes, you guessed right, gravida 4. And a woman with 7 pregnancies will be described as being gravida 7. Good. And so having dealt with G, the next is P, parity. What does it mean? Parity refers to the total number of confirmed previous pregnancies which were carried to viability, whether the outcome was a dead baby or a live baby. So irrespective of the outcome, if the pregnancy was carried to viability, we call that the woman's parity. We will see what viability means in a second, but again, parity answers the question of the total number of confirmed pregnancies in the past, which is the gravidity, how many of them were carried to the age of viability? That is the question parity answers. Now, viability, otherwise known as the age of viability, is a medico-legal term which defines the arbitrary gestational age at which a fetus is adjudged to have a fair chance of extrauterine survival. Now, this is what it means, that there is an age limit defined by law per country which judges whether or not a baby is likely to survive when he or she comes out of the mother's womb. And so in Ghana, that age limit defined by law is 28 weeks. If a baby is born at 28 weeks and beyond, it is adjudged by law that the baby has a fair chance of extrauterine survival. But in other developed countries, this age limit is as low as 22 weeks, while others peg it at 24 weeks. Now, what accounts for the difference in the set viability age in Ghana versus developed countries like the US and the Canada, etc.? This is because those developed countries, unlike Ghana, have the sophisticated facilities and equipment to ensure the survival of a fetus as young as 22 weeks old, which has been expelled. That being said, I must say that though our viability set point is 28 weeks, there have been a few cases where babies less than 28 weeks old have survived in Ghana. And so back to our discussion on parity. It means that if a woman is able to carry a confirmed pregnancy to 28 weeks and beyond, irrespective of the outcome of that pregnancy, that is her parity. And that is the point. And so you ask if the woman carried her pregnancy beyond 28 weeks. So 28 weeks and beyond, if that happens, that is her parity, irrespective of whether the baby died or the baby lived. And so like we did for gravidity, let's explain some terms associated with parity. Nullipara is the first term we need to explain. A woman is described as nullipara or nulliparous if she has never carried a pregnancy to viability. So she may have been pregnant for say 3 times, but if none of them got to 28 weeks and beyond, she is described as nullipara or nulliparous, and so she is para 0. Then we move to primipara. Primipara, the woman has carried 1 pregnancy to viability before. Now, multipara. The multi in this term is deceptive in that it connotes that the woman has or the woman must have 2 or more parities to be described as multiparous, but that is not true. Once the woman has carried at least one pregnancy to viability before, she is a multiparous woman. So a woman who is para 1 is both. Now, still on the terms associated with parity, we have grand multi-para, sometimes informally termed grand multip. And so who is a grand multip? A grand multip is a woman who has carried at least 5 pregnancies to viability, meaning a para 5 is a grand multip. But this definition again varies from country to country. Some jurisdictions actually peg it at 4. So a para 4 is a grand multip in some jurisdictions, but in Ghana, a para 4 is simply described as a multip. Now, watch out. How will you describe the parity of a woman whose single pregnancy resulted in twin or triplet or quadruplet delivery? Will you say she is para 2 because she delivered twins, or maybe para 3 because she delivered triplets? Now, if a woman carries a multiple gestation, meaning maybe she has one pregnancy which resulted in twin formation, triplet formation, or quadruplet formation, etc., and she's able to carry that pregnancy to viability, she is still para 1. Alright friends, please do not forget to like and share this video and subscribe to our channel if you have not done that yet. We've dealt with G, P, and so we are left with A. A stands for abortion. And so a woman is said to have had an abortion if the baby or the fetus is expelled before the age of viability, and the baby came out showing no signs of life. Once that happens, we say that the baby is an abortus. But if the baby shows a sign of life despite being expelled before the age of viability, it is a live birth and so should be considered parity. And so this is where the confusion is. Parity by definition should be a baby who has been carried to the gestational age of viability and then beyond. If it is expelled, it is still parity. And an abortus is a baby who is expelled before the age of viability. What you are saying is that if the baby is expelled before the age of viability and comes out showing no signs of life, then it is an abortus. Once it shows a single sign of life, it is considered a live birth. A single sign of life or signs of life like struggling or attempting to breathe or moving any of its body parts, that's a sign of life, and that is a live birth. And so, how is the gravidity parity abortion notation written? For a pregnant woman, if the woman is pregnant, it is the gravidity with its number, parity with its number, plus abortion with its number. And so, for example, we have gravida 6, para 4, plus 1. What this means is that this woman has been pregnant 6 times and is actually currently pregnant. Out of the 6 pregnancies, she has carried 4 to gestational age of viability, and then 1 was an abortus. So she is currently pregnant. That is why she is gravida 6, para 4, plus 1. Now, if the woman is not a pregnant woman, say you are taking a gynae history, and then you want to express the woman's obstetric history with the GPA system. If the woman is not pregnant, there is no need to bring the gravida. It is simply written as the parity with its number plus the abortion with its number. So an example is para 4 plus 1. What this means is that this woman is currently not pregnant, but she has had 5 pregnancies before, 4 of which were carried to viability, and 1 unfortunately became an abortus. And so to sum everything up, a woman who is currently pregnant and had a set of twins, had 2 stillbirths, 2 ectopic pregnancies, and 1 spontaneous miscarriage, how would you describe the obstetric score of this woman? How many times has she been pregnant at the time you are seeing her? So she's currently pregnant, that is 1. 2, she had a set of twins from a single pregnancy, so that is also 1. So you have 2 now. She had 2 stillbirths, that is plus 2, so we have 4 pregnancies. She had 2 ectopic pregnancies, we have 6, and then 1 spontaneous miscarriage in the past. So we have 7 total confirmed pregnancies, and so she's gravida 7. Now let's move to the parity. She had a set of twins, so they are alive. Once they are alive, it means that they went past the age of viability, so that is 1. And she had 2 stillbirths. This means she carried 2 babies to viability, but unfortunately they didn't survive, and so that is parity. So 2 plus the 1 is 3. So she has para 3, but 2 are dead, and so we report that as para 3 2D. It means 2 are dead. Then we move to the A part. She had 2 ectopic pregnancies. Likely they didn't reach the viability age, and she had 1 spontaneous miscarriage. So that is also an abortion. So that is 3 miscarriages or 3 abortions, and so in total the obstetric score is gravida 7, para 3, 2 dead, plus 3. Welcome back. Well done for staying on course when we're discussing the first information we need to master, which is the GPA system. Now the next parameter is the LMP, which means last menstrual period. Now, although it is known as the LMP is actually the first day of the last normal menstrual period prior to conception or prior to pregnancy. When you ask the woman, can you tell me your last menstrual period? They are likely to give you the last day of their menstrual period. But remember, what you are interested in is the first day of their last menstrual period, and that menstrual period has to be normal. Now, the LMP is used to determine the expected date of delivery and the gestational age of the baby, and so it is important that the clinician establishes the last normal menstrual period well, because if we miss that, we are likely to get the expected date of delivery wrong and the gestational age of the baby wrong. Now, assuming we've gotten the woman's LMP, like I said, it is used to determine the expected date of delivery and the gestational age, and so we need to know whether we can rely on the LMP. So we need to determine the reliability of the LMP. So we need to ask questions like, was the menstrual period normal in its date of onset, duration of flow, and the amount of flow? So we ask the woman, did it come on the day you were expecting it, or it varied, or it kept so long, or it came too early? What was the duration of that flow? Was it abnormal compared to your past menstrual periods? And what was the amount? Did it come too much, or it flowed a little? If there is any disparity compared to her previous menstrual periods, then this LMP is likely not to be her normal or her last normal menstrual period, and so is unreliable to use to determine the EDD and the gestational age of the baby. There are other questions to ask, which we'll look at in subsequent slides. Other questions you are interested in include: what was the regularity and length of the menstrual cycles before pregnancy? If the woman is one who has irregular menstrual cycles, we can't really tell when another menstrual cycle is following, then this is not a reliable LMP to use, or else we will date the pregnancy wrongly. Then we also want to know whether she has had any bleeding since what she called her last menstrual period. If she's had any bleeding, then the reliability of her last menstrual period is shaky. We may not rely so much on it. Also, we want to know if she was on any hormonal contraceptives, and if yes, when did she discontinue before she got pregnant? Because we know that after stopping hormonal contraception, the first 2 episodes of bleeding may be anovulatory. It means no eggs were released during that cycle, but the patient still bled, and that is a normal finding in women who have recently stopped a hormonal contraceptive. And so if she gives you that bleeding period as her last normal menstrual period, the EDD or the gestational age calculated from such a date is not likely to be correct. And so you want to know her hormonal contraceptive history prior to pregnancy. And so to give an example of a last menstrual period, an example is, my last menstrual period was 26th June 2023. Once you get this date, establish the reliability of this last menstrual period. And kindly note that most patients will give you the last day of the period. Please remind them that you want to know the first day of the period, because that is where you are going to use to date your pregnancy, or that is what you are going to use to date your pregnancy, I wanted to say. Now, as far as the expected date of delivery and gestational age calculation is concerned, you can use the woman's LMP or use a first trimester scan for that. So we want to compare the reliability or the accuracy of using the LMP to calculate the gestational age and EDD compared to that which is gotten from a first trimester scan. I want to say that even when the woman is very sure of her LMP, the first trimester scan is used to date every pregnancy. Most women may not be sure, but even those who are educated and are so sure of their LMP, if they have the first trimester obstetric scan, we use that to date every pregnancy. And so as part of the history taking, once you get the LMP, the clinician may ask the patient whether he or she, the patient, so she has taken a scan in this pregnancy, and when it was taken, if you get the scan which was taken the first trimester, and usually after 7 weeks, so between 7 weeks and 13 weeks, if the woman has taken a scan like that, then you can use that scan to date your pregnancy. You choose the obstetric scan over your LMP, because the obstetric scan which is taken in the first trimester is more accurate in determining the EDD and the gestational age compared to the LMP, especially when your patient's level of education is not so high.